Chickenpox in pregnancy. Green Tap Guideline number 13. Purpose and scope. Varicella. The primary infection with varicella zoster virus or VZV, also known as the human herpes virus 3, in pregnancy may cause maternal mortality or serious morbidity.
It may also cause fetal varicella syndrome or FVS and varicella infection of the newborn, which includes congenital varicella syndrome or CVS and neonatal varicella.
The varicella zoster immunoglobulin or VZIG is manufactured from the plasma of human blood donors and hence is a limited and expensive resource. Introduction and background epidemiology. VZV, or the varicella zoster virus, is a DNA virus of the herpes family that is highly contagious and transmitted by respiratory droplets and by direct personal contact with vesical fluid or indirectly via fomites such as skin cells, hair, clothing, and bedding. The primary infection is characterized by fever, malaise, and a pruritic rash that develops into crops of maculopapules, which become vesicular and crust over before healing. The incubation period is between 1 and 3 weeks, and the disease is infectious 48 hours before the rash appears and continues to be infectious until the vesicle crust over. The vesicles usually crust over within 5 days. Over 90% of individuals over 15 years of age are seropositive for VZV, immunoglobulin G, IgG antibody. The primary varicella zoster virus infection in pregnancy is uncommon. It is estimated to complicate 3 in every 1,000 pregnancies. Women from tropical and subtropical areas are more likely to be seronegative for varicella zoster virus immunoglobulin and are therefore more susceptible to the development of chickenpox in pregnancy. Following the primary infection, the virus remains dormant in sensory nerve root ganglia, but can be reactivated to cause a vesicular erythematous skin rash in a dermatomal distribution known as herpes zoster, also called zoster or shingles. The risk of acquiring infection from an immunocompetent individual with herpes zoster in non-exposed sites such as thoracolumbar is remote but can occur. However, disseminated zoster or exposed zoster, such as ophthalmic, in any individual or localized zoster in an immunosuppressed patient should be considered to be infectious as the viral shedding may be greater. Varicella prevention. Can the non-immune woman be immunized prior to pregnancy or postnatally? Varicella vaccination pre-pregnancy or postpartum is an option that should be considered for women who are found to be seronegative for varicella zoster virus immunoglobulin. While universal serological antenatal testing is not recommended in the UK, seronegative women identified in pregnancy could be offered postpartum immunization. Women who are vaccinated postpartum can be reassured that it is safe to breastfeed. Varicella vaccine contains live attenuated virus derived from the Oka strain of varicella zoster virus. Immunity from the vaccine persists for up to 20 years. The varicella immune status of women planning a pregnancy or receiving treatment for infertility can be determined by obtaining a past history of chickenpox and by testing the serum for varicella antibodies in those who have no history or an uncertain history of previous infection.
If a woman of reproductive age is vaccinated, she should be advised to avoid pregnancy for 4 weeks after completing the 2-dose vaccine schedule and to avoid contact with susceptible pregnant women should a post-vaccination rush occur. Transmission of vaccine virus is rare despite it being a live attenuated virus. Inadvertent exposure to the vaccine in pregnancy have been reported to a register. There have been no cases of FVS and no increase in the risk of fetal abnormality above the background risk.
Can varicella be prevented in the pregnant woman at her initial antenatal visit? Women booking for antenatal care should be asked about previous chickenpox or shingles infection. Women who have not had chickenpox or are known to be seronegative for chickenpox should be advised to avoid contact with chickenpox and shingles during pregnancy and to inform healthcare workers of a potential exposure without delay.
A previous history of chickenpox infection has a 97.9 to 99.7% positive predictive value for the presence of serum varicella antibodies in women booking for antenatal care in the USA. Individuals born and raised in tropical climates are less likely to be immune to varicella, and a history of chickenpox can be a less reliable predictor of immunity in this population.
It may be appropriate to undertake serum screening routinely in this group of women. If seronegativity is identified, a postpartum vaccination could be considered. Can varicella infection be prevented in the pregnant woman who gives a history of contact with chickenpox or shingles? If contact occurs with chickenpox or shingles, a careful history must be taken to confirm the significance of the contact and the susceptibility of the patient. Pregnant women with an uncertain or no previous history of chickenpox or who come from tropical or subtropical countries who have been exposed to infection should have a blood test to determine varicella zoster immunity or non-immunity. If the pregnant woman is not immune to VZIG and she has had a significant exposure, she should be offered VZIG as soon as possible. VZIG is effective when given up to 10 days after contact. In the case of a continuous exposures, this is defined as 10 days from the appearance of the rash in the index case. Non-immune pregnant women who have been exposed to chickenpox should be managed as potentially infectious from 8 to 28 days after exposure if they receive VZIG, and from 8 to 21 days after exposure if they do not receive VZIG. When supplies are limited, issues to pregnant women may be restricted, and clinicians are advised to establish the availability of VZIG before offering it to pregnant women. Women who have had exposure to chickenpox or shingles, regardless of whether or not they have received VZIG, should be asked to notify their doctor or midwife early if a rash develops. A pregnant woman who develops a chickenpox rash should be isolated from other pregnant women when she attends a general practice surgery or a hospital for assessment. A second dose of VZIG may be required if a further exposure is reported and 3 weeks have elapsed since the last dose. The history must be confirmed with particular respect to the following. First is the type of varicella zoster virus infection. Second, the timing of the exposure. And third, the closeness and duration of contact. Chickenpox is infectious for 2 days before the appearance of the rash and for the duration of the illness, while the skin lesions are active. It ceases to be infectious when the lesions have crusted over. Herpes zoster or shingles also poses a risk if it is disseminated or it occurs in an exposed area of the body, such as the ophthalmic shingles, or in an immunocompromised individual where viral shedding may be greater. The risk of infection following contact with herpes zoster that is not in an exposed area such as thoracolumbar shingles is remote but can occur. Significant contact is defined as a contact in the same room for 15 minutes or more, face-to-face contact, or contact in the setting of a large open ward. The susceptibility of the woman should then be determined by eliciting a past history of chickenpox or shingles. If there is a definite past history of chickenpox, it is reasonable to assume that she is immune to varicella infection. If the woman's immunity to chickenpox is unknown, and if there is any doubt about previous infection, or if there is no previous history of chickenpox or shingles, serum should be tested for VZIG IgG. This can usually be performed within 24 to 48 hours, and often within a few hours, if the laboratory can access serum stored from an antenatal booking blood sample. Varicella zoster immunoglobulin is indicated after significant exposure to varicella zoster virus at any stage of pregnancy, and postnatally if birth occurs within 10 days of exposure. If the immune status of the woman is unknown, the administration of VZIG can be delayed until serology results are available. The rationale for administration of varicella zoster immunoglobulin is that it may prevent or attenuate chickenpox in non-immune individuals, and it may reduce the risk of development of FVS or fetal varicella syndrome. Adverse effects of VZIG include pain and erythema at the injection site. The risk of anaphylaxis is cited as less than 0.1%. Patients with hypogammaglobulinemia with immunoglobulin A antibodies who are already receiving placement therapy with immunoglobulin do not require VZIG and are at risk of anaphylactic reactions. No case of blood-borne infections has been reported with the use of VZIG. Despite the benefits of VZIG in preventing or attenuating the disease, pregnant women may still become seriously ill. What are the maternal risks of varicella in pregnancy? Clinicians should be aware of the increased morbidity associated with varicella infection in adults, including pneumonia, hepatitis, and encephalitis. Rarely, it may result in death. The incidence of pneumonia complicating varicella in pregnancy has been quoted at 10 to 14%. Pneumonia may be more severe at later gestational age due to the effects of the gravid uterus on respiratory function. Now, how should a pregnant woman who develops chickenpox be cared for? Pregnant women who develop a chickenpox rash should immediately contact their general practitioner. Women should avoid contact with potentially susceptible individuals, such as other pregnant women and neonates, until the lesions have crusted over. This is usually about 5 days after the onset of the rash. Symptomatic treatment and hygiene is advised to prevent secondary bacterial infection of the lesions. Oral aciclovir should be prescribed for pregnant women with chickenpox if they present within 24 hours of the onset of the rash, and if they are 20 plus weeks of gestation or beyond. The use of aciclovir before 20 plus weeks should also be considered. Aciclovir is not licensed for use in pregnancy, and the risk and benefits of its use should be discussed with the woman. Intravenous aciclovir should be given to all pregnant women with severe chickenpox. VZIG has no therapeutic benefit once chickenpox has developed and should therefore not be used in pregnant women who have developed a chickenpox rash. Aciclovir is a synthetic nucleoside analog that inhibits replication of the varicella zoster virus. A randomized controlled trial has shown that aciclovir administered orally 800 mg 5 times a day for 7 days reduces the duration of fever and symptomatology of varicella infection in immunocompetent adults if commenced within 24 hours of developing the rash. Data are accumulating to suggest that there is no increase in the risk of major fetal malformation with aciclovir exposure in pregnancy. Should women be referred to a hospital? Pregnant women with chickenpox should be asked to contact her doctor immediately if she develops respiratory symptoms or any other deterioration in her condition. Women who develop the symptoms or signs of severe chickenpox should be referred immediately to hospital. A hospital assessment should be considered in women at high risk of severe or complicated chickenpox, even in the absence of concerning symptoms or signs. This assessment needs to take place in an area where she will not come into contact with other pregnant women. Appropriate treatment should be decided in consultation with a multidisciplinary team that includes an obstetrician or fetal medicine specialist, a virologist, and a neonatologist. Women hospitalized with varicella should be nursed in isolation from babies, potentially susceptible pregnant women, or non-immune staff. Respiratory symptoms, neurological symptoms such as photophobia, seizures or drowsiness, a hemorrhagic rash or bleeding, or a dense rash with or without mucosal lesions are indicative of potentially life-threatening chickenpox and are indications for referral to a hospital with intensive care access. If the woman smokes cigarettes, has chronic lung disease, is immunosuppressed, including those who have taken systemic corticosteroids in the preceding 3 months, or is in the second half of pregnancy, a hospital assessment should be considered even in the absence of complications. When and how should the woman with chickenpox be delivered? The timing and mode of delivery of the pregnant women with chickenpox must be individualized. When epidural or a spinal anesthesia is undertaken in women with chickenpox, a site free of cutaneous lesions should be chosen for needle placement. Depending on the severity of the maternal condition, a respiratory physician and intensive care specialist may be involved in peripartum care. Delivery during the viremic period while the chickenpox vesicles are active may be extremely hazardous. Delivery may precipitate maternal hemorrhage and/or coagulopathy due to thrombocytopenia or hepatitis. There is also high risk of varicella infection of the newborn with significant morbidity and mortality. Supportive treatment and intravenous aciclovir are therefore desirable, allowing resolution of the rash, immune recovery, and transfer of protective antibodies from the mother to the fetus. Ideally, a minimum of 7 days should elapse between onset of the rash and delivery. However, delivery may be required to facilitate assisted ventilation in cases where varicella pneumonia is complicated by respiratory failure. There is no evidence available to inform decisions about the optimum method of anesthesia for women requiring delivery by cesarean section. General anesthesia may exacerbate the respiratory compromise associated with varicella pneumonia. There is a theoretical risk of transmitting the varicella zoster virus from skin lesions to the central nervous system via spinal anesthesia. As the dura is not penetrated, epidural anesthesia may be safer than spinal anesthesia. However, the larger needle required for epidural anesthesia carries the theoretical risk of transferring a greater viral load from the skin to the epidural space. Risk of maternal varicella infection to the fetus or baby. What are the risks to the fetus of varicella infection in pregnancy, and can they be prevented or ameliorated? Women should be advised that the risk of a spontaneous miscarriage does not appear to be increased if chickenpox occurs in the first trimester. If the pregnant woman develops varicella or shows serological conversion in the first 28 weeks of pregnancy, she has a small risk of fetal varicella syndrome, and she should be informed of the implications.
Fetal varicella syndrome, or FVS, is characterized by one or more of the following: skin scarring in a dermatomal distribution, eye defects such as microphthalmia, chorioretinitis or cataracts, hypoplasia of the limbs, and neurological abnormalities such as microcephaly, cortical atrophy, mental retardation, or dysfunction of bowel and bladder sphincters. It does not occur at the time of initial fetal infection, but results from a subsequent herpes zoster reactivation in utero and only occurs in a minority of infected fetuses. FVS has been reported to complicate maternal chickenpox, occurring as early as 3 weeks and as late as 28 weeks of gestation. The risk appears to be lower in the first trimester, 0.55%. Post-exposure prophylaxis in susceptible pregnant women reduces the risk of developing fetal varicella syndrome.
Can varicella infection of the fetus be diagnosed prenatally? Women who develop chickenpox in pregnancy should be referred to a fetal medicine specialist at 16 to 20 weeks or 5 weeks after infection for discussion and detailed ultrasound examination. Given that amniocentesis has a strong negative predictive value but a poor positive predictive value in detecting fetal damage that cannot be detected by non-invasive methods, women who develop varicella infection during pregnancy should be counseled about the risk versus benefits of amniocentesis to detect varicella DNA by polymerase chain reaction or PCR. Amniocentesis should not be performed before the skin lesions have completely healed. Prenatal diagnosis of FVS is possible by ultrasound when findings such as limb deformity, microcephaly, hydrocephalus, soft tissue calcification, and fetal growth restriction can be detected. A time lag of at least 5 weeks after the primary maternal infection is advised because ultrasound performed at 4 weeks has failed to detect the abnormalities. Fetal magnetic resonance imaging, or MRI, may provide additional information in cases where ultrasound has identified morphological abnormalities. What are the neonatal risks of varicella infection in pregnancy, and can they be prevented or ameliorated? If maternal infection occurs in the last 4 weeks of a woman's pregnancy, there is a significant risk of varicella infection of the newborn. A planned delivery should normally be avoided for at least 7 days after the onset of the maternal rush to allow for the passive transfer of antibodies from mother to child, provided that continuing the pregnancy does not pose any additional risk to the mother or baby. A neonatologist should be informed of the birth of all babies born to women who have developed chickenpox at any gestation during pregnancy. Women with chickenpox should breastfeed if they wish to and are well enough to do so. Varicella infection of the newborn, previously called congenital varicella, refers to VZIG infection in early neonatal life resulting from maternal infection near the time of delivery or immediately postpartum or from contact with a person other than the mother with chickenpox or shingles during this time. The route of infection could be transplacental, ascending vaginal, or result from direct contact with lesions during or after delivery. If maternal infection occurs 1 to 4 weeks before delivery, up to 50% of babies are infected and approximately 23% develop clinical varicella, despite high titers of possibly acquired maternal antibody. Severe chickenpox is most likely to occur if the infant is born within 7 days of onset of the mother's rush or if the mother develops the rash up to 7 days after delivery. For babies born to mothers who have had chickenpox within the period 7 days before to 7 days after delivery, it is therefore vital that the neonate receives prophylaxis as soon as possible with VZIG, with or without aciclovir. There is no need to test in these circumstances. If there are active chickenpox lesions close to the nipple, they should express breast milk from the affected breast until the lesions have crusted over. The expressed breast milk may be fed to the baby who is receiving treatment with VZIG and or aciclovir.